Hello there, thank you and welcome. Thank you for joining us on another edition of the Evening Review. My name is Okito Greg. In studio with me this evening we have Dr. Nelson Makemba, who will be sharing with us insights. Dr. Nelson, how are you, sir?
Good evening to you, Greg, and good evening to the viewers, and I'm excited to be here. Thank you for having me.
Thank you very much.
Yeah.
The government is about to institute wide-ranging reforms for medicine here in Namibia. Tell me, as a member of the private medical sector, has the private sector been consulted or involved in preparations for these reforms?
I think if you first and foremost, let me establish our conversation based on the fact that the private sector and the state sectors, when it comes to medical fraternity, are complementary factors.
Okay.
We have to establish the fact that they are not competing against each other, but they are complementing each other.
Yes.
So what we would have then hoped to see under normal circumstances is that the two sectors brought on the same table.
Yes.
So that when a framework is established on how things are going to unfold, at least there's an understanding from both sides so that we are all then accommodated in that way. I should say, with the current directives that we are now looking at that are probably going to start unfolding going forward, there has actually been little, involvement, of the private sector, so to say. Most of the individuals and, entities in the private sectors are probably still not as sure as to what the directives really means and where does that leave the private sector in terms of, them being also participatory, involvement into, the decisions that are unfolding here.
Yeah. Oh. The Minister of Health and Social Services, Dr. Esperance Levendau, has announced in Parliament her Vision April 2026. Were you, as a member of the private sector medical fraternity, were you involved in any way? Did she consult? Did she include you in the preparations for this vision?
Look, if you look at how the things are set up in our fraternity, for instance, we have associations and bodies to which we answer to. Mm-hmm. One is the Health Professions Council of Namibia, that is a statutory body that we register to.
Yes.
And then we also have various organizations to which we are members and part to. Most of these associations, have not really, communicated to us as their member to say this is, our involvement. That then would probably insinuate that, we were not really, properly involved. When the directives were given, we welcomed the directives, but obviously it has also created some level of uncertainty in the industry to say, what are things going to look like, going forward. So one would have hoped for more consultative type of an approach where maybe the sectors were brought together on one table, an understanding, a decorum of some sort must have been established. And then, with the kind of expertise, and experiences, based on, the individuals that are found in the industry, then, understanding, knowledge could be brought forward, to sort of try and, structure whatever changes and reform one is hoping for in a way that is accommodative of both of us. So I'm now beginning to see a little bit of reformation and maybe, an attempt to involve, various organizations. But that probably was then only done at a later stage, which one would have hoped to say that, maybe that should have been the first point of call when a decision was made to say, bring everybody on the table. Let's discuss and let's formulate, the way forward going together.
And part of that Vision April 2026 is that from the 1st of April, all PSEMAS members, including senior government officials and lots of other people, will be required to make use of state facilities. Are you well informed about that? What do you expect that will mean in a practical sense?
Yeah, if you look at it from the practical point of view, as it stands already, most of the state facilities are overwhelmed by the numbers of the patients that they have to deal with that are not necessarily on medical aid.
Yes.
And we also understand from the data that is provided to say that individuals that are on PSEMAS as it stands is something north of 400,000 people in the country. So that is almost 60% of the entire medical fraternity as we stand. Now, if the facilities are seemingly under pressure from the numbers that are in place now, and then if you are going to add another 400,000 on top of the numbers, you should expect there to be a little bit of overwhelming sort of activities unfolding within the state facilities.
I can imagine.
And also the way health services is structured as it stands, especially with the state, is that when you are not feeling very well, your first point of call is going to the clinic. Then that's a primary health care level. At the clinic, you are evaluated, and you are either managed there at the primary health care level, or if the primary health care level then deem and see the necessity to refer you, then they refer you to the intermediate facility. So you will now imagine how the queues are going to be like at the clinic, for instance, should the directives go through. You probably are going to have a little bit of increased number in terms of the volume that is going to also rock up at the clinics. And also, I'm not entirely too sure of how the modality is going to be like, because you are now going to have individuals without medical aid and those with medical aid. Also navigating that space, because if I'm coming now to the clinic and I have medical aid, I expect a certain standard. Number one, I have expectation because I feel I'm having medical aid and I'm paying for the service.
Paying for it.
Yeah, so how the ministry is going to set up, the nitty-gritties that goes with, managing this kind of, issues that might come up, is something that we are yet to see, because we have not been in that space yet. So one hopes that, perhaps there's a system in place. Also, if the idea is then to also help the ministry, perhaps maybe exercise claiming, from the medical aid, you also have to look at, them setting up systems that will facilitate them to claim from the individual's medical aid. All of these things, are infrastructures that don't just, unfold overnight. You sort of need to take a feasibility study. You need to set up infrastructure. You might also need to train people that might then be dedicated purely for the services of claiming from this kind of, insurances or medical aid for the patients that are going to come at the clinic. And if those systems are not in place and there's no adequate training that has unfolded, it might prove to be very difficult at first, for the ministry to then, maximize the potential of realizing, these claims, and then channeling those resources into upgrading the facility. And also one thing is, one would have hoped for the facility to be upgraded first, before then you can have people coming to make use of the facility. So we are yet to see how things are going to unfold. But again, that's probably what might fuel some of, the uncertainties in the industry at the moment.
I can imagine.
Yeah.
Do you have any idea how it will work in terms of the fact that the government subsidizes a lot of the medicines and a lot of the treatment that people who are not on medical aid get?
Yeah.
So now we are both at the same facility.
Yeah.
We are receiving the same treatment.
Yeah.
I'm not on medical aid, you are on medical aid.
Yes.
At the end of the day, does your medical aid have to pay for something that I get subsidized?
Yeah, I think if you were to look at it, critically, it probably sounds as such, because now we are making use of the same facilities, and obviously when you have seen the healthcare provider and perhaps a prescription is issued or it's written in your passport, then you have to proceed to the pharmacy, which is also within the same system. So it then would mean that, the medical aid that I have that you don't have, also in a way it's subsidizing for the services, that you are getting. As it stands, there has been a lot of bottleneck issues within the system, because of the huge volume and number of people that the state is serving. Sometimes also you find some medications, are not stocked at the state facilities as it stands right now. You find people might go to the health facility and the doctor wishes to prescribe a certain item. And then unfortunately the doctor then learns that the pharmacy doesn't have that item. We have seen also in our private space, individuals that have been seen at the state will then come and say, okay, my grandmother had gone to the state. The doctor would have liked to prescribe A, B, and C, and unfortunately the pharmacy didn't have it. Can you then in your private capacity help us issue a private prescription so that we can procure these items from a private pharmacy? Yeah, so those are the challenges that, the system is faced with right now. Now, you go to that facility with your medical aid, and you are told that item that you ought to be taking is no stock. I don't think that will probably sit well with an individual that's on medical aid, because then my question is, I have medical aid and I'm able to at least somehow afford to pay for these services. If I'm able to afford to pay for these services, why then should I be compelled to use a system that is not able to meet my need? So those are the tough spaces and tough questions that, obviously going forward, the directives that has been given, the ministry and officials involved probably need to navigate. Yeah.
But that only applies if I'm on PSEMAS.
Yes.
So if I have private medical aid, not PSEMAS medical aid, does that mean that I can still start my health journey at a private facility? Or will I be required as a citizen of Namibia to go to a state facility first before I can then access private healthcare in the country?
For as far as I'm concerned, the directives are specifically only for PSEMAS at the moment.
Okay.
So which means individuals that have other form of private medical aid or medical insurances, probably still business as usual. They can go to their private clinics, they can go to their private doctors and access their services as they usually do. The only one challenge that I also have with the directive, for instance, is let's say you have PSEMAS medical aid. You have been my patient for the last 10 years. You have a file with me, I have all their records. I have obviously journeyed with you for the last 10 years. Let's say, for instance, you're on a chronic prescription of some sort. I've sort of navigated the space. I've come to establish a dosage and a molecule that works well for you. Minimal side effect, best outcome, blood pressure is controlled, cholesterol is doing fine, the sugars are controlled. It then becomes a bit of, a break in continuity of care.
Yes.
Because now you have to go to a different facility, start all over again from the beginning, having to explain yourself as to what your condition is, and then the doctor has to start running tests again.
Yes.
Then restarting, issuing a prescription, and then, trying to navigate that space until they get your things controlled for you. So that also might then mean that, we are going to see a lot of, hiccups, especially when the transition is taking place. Because if you are now going to be using the state facilities only, it means that then the guy that has been looking after you for the last 10 years is cut out.
Sure.
Yeah, so if he's cut out, then it means that, not much is going to be, carried over because, the information that I have on you is limited to my clinic.
Yes, yes.
And, that is between me and you. Patient private confidentiality matter also. Yeah.
Dr. Nelson, we just got to take a break right there because we got to go to a commercial break, but we'll be right back to continue this conversation on the Evening Review. Welcome back to the Evening Review. My name is Ogito Greg, and in studio with me this evening in conversation with Dr. Nelson Makemba, he's explaining to us the expected impacts of the reform to the medical fraternity. Doctor, I wanted to find out, with all these PSEMAS patients that might be lost to the private sector, what do you think will be the impact for private medical practice in Namibia and for your own practice?
Yeah. If you look at the number, Greg, if we are saying that individuals that are on PSEMAS are about 400,000 plus,
Yeah.
that probably constitutes 60% of the entire sector. So it also means that then that 60% is taken out of the private sector, and then it's channeled back to the state. That might then also mean that revenue to the private sector is also expected to take a knock.
Yes.
Different facilities comes in with different terms of workforce. If you were to compare, for instance, a GP practice, a clinic versus a hospital.
Yes.
Now, in as much as health is an essential, service that need to be given to everybody, for the private sector also to successfully deliver the services and be efficient, there has to be a realization of some sort of profiting from the enterprises and the activities that goes with it. If you take away that 60%, it might mean then you are going to cause a dent in the sector. The question will then mean, going forward, are we going to also be looking at possibly laying off of staffs from different clinics, hospitals, and offices, because now the revenue that was once created, is no longer there.
Yeah.
So there will be that question that will be at the back of the mind of individuals that are in the sector to say, what becomes of my workforce, if I'm no longer able to cater for the PSEMAS patient. And that might actually mean a lot of changes also that we as private care practitioners might need to think of instituting should the directives go through.
You know, what you are saying, it brings to mind the fact that Namibia has very high standards of medical care here. In fact, we even support medical tourism within the region and within the world. Do you think that this change, this reform, could impact the standards of care that is available in Namibia in the future?
It will definitely, Craig, it will definitely impact, your ability to deliver on quality, because medicine itself as an exercise is a very expensive exercise, both for private and the government. A lot of what we do, requires a lot of, financial injection into keeping the machine going.
Yes.
Keeping facilities up to standard, keeping theater facilities up to standard, keeping intensive care units up to standard. The machines sometimes that, we use, be it, anesthetic machines, machines that are needed to ventilate individuals when they are on oxygen and life supports, they are very expensive to procure. Number one, they are very expensive to maintain. The CT scan machines, the MRI scans, they are very expensive to procure and they are very expensive to maintain. Yes. So, in as much as, we have to find a common ground in also meeting our people's needs, we also need to also find a common ground in creating enough revenue that will be able to sustain the standards. Now, if you take away the 60%, which is the PSEMAS, entirely so from the private sector, it means a lot of things. And obviously, we can't speak to what it will look like because we have never been there before. So we are going to enter a new space. We will have to now navigate that space going forward. A lot of uncertainty as it is for now, but we are yet to see what then that means financially, the impact it will have on the sector as a whole, and the readjustment that need to take place so that the sector can still function, even if that 60% is taken away.
Let's talk a little bit about capacity. You did hint at it previously, but I'm thinking, the way especially the private medical care works. Often I will go to the doctor, I've got medical aid, and then the doctor will claim from the medical aid. So there needs to be capacity in the doctor's office, but there also needs to be capacity at PSEMAS for these claims, especially if the claims are now coming from institutions which are not familiar. How much capacity is that? Can it quickly be fixed, like in a week, or do you think it'll take longer?
The reality of the matter is it takes a lot of time. First and foremost, you have to look at capacity from the institution's point of view, to say, look, if we are going to take every PSEMAS client and send them to the state facilities, are the state facilities equipped to then claim? In other words, do they have clerks that understand how the claiming systems works, the coding system? Because our claims are coded. Everything comes coded. There's a lot of regulations that goes in the medical fraternity, and that also is because you want, the system to be as much ethical as it can be, because you are working with humans' life. You don't want people to get overly excited and becoming unethical in their behavior. So therefore, the coding system that is provided for by NAMA, for instance, that guides us how we claim from the medical aid when we have rendered services to the patient. Now, whether the facilities within the state sectors are equipped to do that, that is something that one is yet to look and see what's going to unfold there. Primarily because they were not necessarily used to being in that space. And for you to have individuals that are able to do that, and then you maximizing, from the exercise, you need to train, expose the people to the systems that are needed in order for you to do that. And also, that is without saying that you now have to have infrastructure then developed within your clinics and your hospitals. You need to train your clerks, and also your doctors, your nurses, and every healthcare provider that is involved. If I am sitting at Black Chain or Chomisa Clinic, I've never done private works at all. I might not be crewed up with the systems. Now, if I start seeing patients, and if the idea is for the facility to claim, then you have to train me, because now for me to also put the exercise to maximum use, I need to understand how that will go. As to whether colleagues within the state facility has had that exposure, I'm not entirely too sure. I've never really heard of any drive, that is geared at training them and then bringing them to pass so that they are able to then claim. So those are some of the things that probably now, the ministry plus, everybody involved might have to look at. My hope is that perhaps there's a strategy to it. And then obviously we are yet to see how that will unfold as well.
You know, PSEMAS, it was just announced this week that PSEMAS has a new board, new leadership that was appointed. Do you have confidence that they'll be able to get this on the ground changes to happen smoothly?
Look, Craig, I think the one thing that we probably acknowledge as healthcare provider, meaning doctors particularly, it doesn't matter whether you are in the private sector or in the state sector. For a very long time, particularly in our Namibian setting, is that most of the bodies that drives, the governance that goes within the industry, formulating policies and making, major decisions for the industry, have always been everybody else except us, the doctors, who are involved, who are basically, engaging, patients on a daily basis. I've looked at the composition when the names and the structure was pronounced yesterday, and I'm sure, the Office of the Prime Minister has gone into establishing a committee. I tried to look, and I'm not really seeing a greater representation of doctors themselves. And one would have hoped to say, look, the kind of reform you are hoping to drive, at least try to involve 1 or 2, 3 or 4, maybe pick, a few from the state sector, pick a few from the private sector. And then also tie in the expertise, and the experience that they have, having been in the industry for a very extended period of time. We have people that have been around for years, over 20 years in the industry. At least bring those people in, so that they are able to help also guide the industry. Because remember, as I've highlighted to earlier at the beginning of our conversation, the private sector seek to complement the state. We are not competing with each other. And in the end, really, be it consuming, health services at the state level or at the private level, the industry is serving Namibia as a whole. So we shouldn't make it look like now, the state is on its own and the private is in its own, and we are sort of competing. If we have that kind of mindset, we might miss each other.
Doctor, there's a concern that I have as a Namibian citizen. And it comes from one of the things during parliamentary discussions. It was alluded that some officials, their time is too valuable to stand in line for 6 hours. So there's going to be a separate entrance for them. And my logic says that what we seem to be creating is a two-tier system within the state, whereas some people get seen to first, they get maybe even better access to medicines, better access to care, and other people do not. Do you think that is what's going to happen? Do you think it's avoidable? How can we stop that from happening? Because I think as a Namibian, I don't want to see that happening at the state level. Because at the state level, it should be for everybody.
That question is very good, Greg, that now that you asked it. The challenge you're going to have really, like you have highlighted too, it's different when, let's say, a senior government official now comes to the clinic. Let's say a minister, prime minister, head of state. Because now, when they come to make use of the services, they are probably going to be coming with their entourage, with the security guard and everything else. So when they get to the facility, I'm not too sure whether they are going to join the queue just like everybody else. Or it's going to be an issue of, okay, now the individual is here, let's quickly serve them, and then off they go. Now, if that is going to be the system, you cannot say then that the experience is the same with the ordinary citizen. Because the ordinary citizen might get to the clinic at 6 o'clock in the morning and only be helped at 1500 hours in the afternoon. Now, and if we are going to say that we want all the officials to consume the state facility, and if we are saying that if it's good enough for ordinary citizen, it must be good enough for government officials, then, are we then saying that if senior officials come to the facility, if they come and there's already 100 people in front of them, then they become 101? And then they just sit in the queue and then continue following the process everybody else? Or do we now halt the queue, put everything to hold, and then save them and then release them? Because if we do that, then what you're talking about then becomes a problem. Then
especially with our history.
Definitely.
I mean, surely my life is the same as your life. Even if you're the president and I'm homeless, it's a life.
It's a life still, And if we are going to create a system where you're saying that the system should be good enough for everybody, If I'm going to wait 6 hours, you must also wait 6 hours like I do.
Yes.
And I'm not too sure whether that's going to be feasible. Also now, given the responsibility the senior officials have, because there's also a country to take care of, you understand?
Indeed there
so
is.
if now you have to spend 6 hours in the queue, and then you still have to be back in the office to run the business of the day, that becomes a problem.
And how far will we take it? Will your son also get to have preference? Because
Yes.
you're worried about your son.
Yes.
You can't focus on work, so we've got to treat your son first.
First, and reassure you that everything is fine. So I think what I really am hoping to see happen, Greg, is that reformation should be, something that, first and foremost, you have to get a feasibility study of some sort. Study and see if the exercise is feasible. And then you have to identify areas of bottleneck issues that need to be ironed out first before you roll out the program. I'm not too sure if, maybe care was taken to look at these things objectively in that way. Perhaps, it has been, maybe the communication has not just come out, because we haven't really seen a framework from, the officials that, also seek to guide us as private care, practitioners to say, you have been seeing, our PSEMAS patient, thank you very much. We have acknowledged, the difference that you have made, but now going forward, this is, what's going to be happening. Because remember, in our private clinics, as you have highlighted to earlier, the systems are running a bit efficient.
Yes.
You could quickly call me and say, Doc, tomorrow I want to come in at 10:30. When you go through my door, 10:30 is your appointment time. You are in there, maximum 15 minutes. You are sorted out. You get your prescription. You pass by the pharmacy, back you out to your office. As it stands now, I'm not too sure whether, the state facilities can even have an appointment system, because one of the numbers of people they are seeing. Because if you call and say you want to come at 10:30, they can tell you, but Greg, there's already 200 people here seated.
Yes.
So I can't now let you just come at 10:30 and see me when I have other people to take care of.
Doctor, I'm afraid we're going to have to stop it there because we've run out of time. But thank you very much for sharing your insights. And as a Namibian, I think our audience also, we will try to inform ourselves so that we can try to support the change which is necessary.
Yeah, definitely. We are here to support the change. We want to see the government bring in the necessary change. But I think we just also want, us to be very considerate of a whole lot of things and approach things in a way that is going to be accommodative of everybody.
Thank you very much. And thank you very much for joining us on the Evening Review. Good night.